Good evening. Today is March 11th, 2020, and it is 5:30 on the dot. As a quorum of the committee is in attendance, I'd like to call to order the Central Health Budget and Finance Committee. Agenda item 1, approve the minutes of the February 19th, 2020 meeting of the Central Health Budget and Finance Committee. Any motions?
Second.
All in favor?
Aye.
Any opposed? All right. We have an emergency agenda item, A1, receive and discuss a briefing on Central Health's planned responses to address the potential impacts of COVID-19 and the declarations issued by the World Health Organization, the City of Austin, and Travis County with respect to the virus. Megan Cermak will be presenting. Hi, Megan.
Hi, good evening. I'm Megan Cermak, Manager of Population Health. Generally, I'm in front of you talking about policy, so this is a bit of a departure, but a little bit about my background. I was previously the Disaster Response Practice Administrator at Integral Care, and I've also provided support for disasters during my time at Austin Public Health and at the Hamilton County Health Department in Ohio. So I'm serving as the project manager for the coronavirus response for Central Health. As of today, the World Health Organization declared a global pandemic. This is an unprecedented situation for us at Central Health, but we are planning and preparing as quickly as the situation is evolving. Mike has made it clear that the health and safety of our staff is first and foremost so that we can continue to serve our community, and we have been using that as our guiding principle while planning. So the actions that we've taken so far, I'd like to separate into 3 different categories. We have our staff response, our patients and people we serve response, and the response to the public. So starting with the staff, we have performed a business impact analysis that involves identifying all of our critical business functions, and we are currently testing our business continuity plan to ensure that those with essential functions can work in a telework capacity. This means that all people with essential functions have laptops, work from home capabilities, internet connections, can access all the files, etc. We have updated our rapid response communication plan for this situation and continue to test various communication methods in order to identify the most effective and highest return rate so we can push out urgent messages if needed. And our core team on this plan is meeting daily at a minimum. We have prioritized our personal protective equipment, or PPE supplies, for our most public-facing staff, and that includes eligibility and our medical management teams. We are communicating with our staff regularly with guidance regarding our policies and procedures, our prevention messages, and the resources available to our staff. So that includes Bright Horizons, Aetna, and our Teledoc resources. An email was sent out 2 weeks ago, another one was sent out Friday, and one is going out today. In the event that we are ordered to socially isolate, we'll be rolling out our telework procedures to all employees and work with HR to ensure that anybody who can't work remotely or is an hourly employee doesn't go without pay. So for our patients and the people we serve, we are working closely with community care and ensuring continuity of care through our business continuity plan, or our BCP. This includes prioritizing our payer functions. In regards to the people that we serve directly through our medical management team, they will see little to no disruption in care at this time. We have plans in place to ensure smooth care transitions in the event that we are ordered to socially isolate. As for eligibility, we will prioritize new enrollments, especially those who need testing or care related to the coronavirus in this event, in the event that we are on essential business functions only. And then finally, for the public, there's updated signage at our facilities that is in alignment with the CDC, DSHS, and APH recommendations. We are taking each public meeting on a case-by-case basis, following the city mandates, the target audience of the meeting, and community feedback. We are pushing out information regarding, we are pushing out information provided by the CDC, DSHS, and community care on all of our social media platforms. And we are also using our community health champions and our community advisory committees as information ambassadors to the public. Are there any questions? Any questions? Yeah.
There's no questions from the members, Madam Chair. So I want to publicly thank everybody for dropping what they're doing and being part of Response Team 1. But Megan, also, you've just done a tremendous job of keeping us on task and on target. And thank you very much. Thank you.
Yeah, I can't imagine the stress you're under right now, but thank you so much. It sounded like a very thorough and comprehensive plan, so thank you. All right, well, we have no action on this item, so thank you.
Thank you.
Maybe you can get a little rest.
Yeah. And stay healthy, please. Agenda item 2, discuss and take appropriate action on Central Health owned or occupied real property and potential property for acquisition or lease. Sherry Greenberg and Callum Mead will be presenting, and I believe this is going to go into a closed session.
Yes.
Yeah. So it is March 11th still, right? Yeah, March 11th, 2020. It is 5:36 in the evening, and I announce the board is convening in closed session to discuss agenda item 2 under section 551.072 of the Texas Government Code, deliberation regarding real property. In addition to our Travis County Council, the following Central Health staff may remain for closed session: Mr. Giesland, Ms. Cavazos, Mr. Knodel, Ms. Owens, and Mr. Lamp.
Yeah.
All right.
Good.
All right. So do I say, repeat the date and time? Or just going to number 3? All right.
Hello?
Agenda item 3. Discuss Central Health's historically underutilized business outreach and education activities and statutes related to increasing contracting opportunities for hubs. Lisa Owens will be presenting. Do we need to go into closed session right away? Or
I don't think
is there
so.
open? Okay.
So, all right, good evening, Lisa Owens. Thank you. And as we discussed at the last Budget and Finance meeting, we're back tonight to talk some more about our historically underutilized business policy and outreach and engagement. I did include a summary of our current policy that has not substantive changes but current terminology in it, consistent with other policies that we've shared with you, such as replacing Travis County Healthcare District with Central Health. But the policy of Central Health is to provide full and equal opportunities for disadvantaged or hub vendors to participate in our procurement process and receive contract awards. In addition, we wanted to talk a little bit more about an opportunity to share more information with you at different intercept points in our work with our hub vendors. In traditional reporting, we've shared with you the end result, which is the expenditures. But as I'd like to walk through this evening, we've done a lot of work on an opportunity to report at different levels, such as in the solicitation and outreach phase, collecting data on the number of people participating in our solicitations, as well as measuring the response rate and award rate, and then continuing to report out on expenditures. So I've shared this with you from our last meeting. Our traditional reporting has been on the expenditures that we've had, overall eligible expenditures, as well as those eligible expenditures that have been spent with hub vendors. And keep in mind that our classification of hub vendors is just minority-owned and women-owned businesses who have a current certification, and we recognize several current certifications and are talking about expanding that as well. It does show the trend that our hub expenditures over the last 3 years have remained fairly consistent, and I want to delve in a little bit more about what's different between the increase in eligible expenses compared to earlier years where you see those higher numbers. So this trend just shows a little bit of the same information, but a little bit differently. So it shows our increase in eligible expenses over the past, since FY12, and it shows that in the past 3 years, if you look at the orange line of the hub expenditures, it's been fairly consistent, and I think I reported last time this is averaged over the past 3 years to be about $665,000 with hub expenditures. Those expenditures in our operations are generally consulting, business consulting, facilitation consulting, public relations. It's also professional services such as architecture and staffing services, landscape services, cleaning services, etc. So the changes that we saw in FY19 were this increase in large specialized services, and I want to talk a little bit more about that. We did a little more work to break it down for you by the type of expenses. So in FY19, you'll see we're sharing some broad categories that we provided: services, which is the majority of our eligible expenses, construction, and assets, which is the purchase of tangible assets, and then goods, which is smaller purchases for goods and commodities. So you'll see the trend shows here that we had a significant uptick. We did have an additional almost doubling of our eligible expenses last year, and I wanted to highlight some of the dollars that are driving that. You'll see in services, which is our highest level there, that those expenses are going up, and that's really driven by some specialized services on our campus. I would highlight that we had significant campus expenditures this year in operating the campus. So we work with a campus operation company to operate the campus. That is going to be winding down as we are redeveloping the campus. We also had some really specialized services with low hub participation or low numbers of hubs available to even propose on those, such as abatement and environmental consulting. And then on the construction, we did see increased construction this year. Not exactly the same as what, going back one slide, we saw in FY15 and 16 with the Southeast Health and Wellness Center, which was one large construction company. But our increase in our construction this year is around the CEC Utilities project, as well as a small project we did at a Southeast Health and Wellness leasehold improvement type project. So we did have an increase in construction projects, but at a lower level than we've seen maybe when we've done a major construction project. And then finally, I think we talked about this last week as well, we also had some significant purchases of assets. We bought a lot of medical equipment for our women's health program, as well as a mobile clinic. So our business is changing and growing, and I think we just wanted to highlight what some of those changes are that are very different than the changes that we've seen in the past that have driven some of the percentages. I think we can anticipate it will continue to be fluctuating a lot. As you know, we have a demolition project starting. We will have significant expenditures starting in this year with our demolition company. That is a large construction project. And so we will continue to see those fluctuations going forward. But in addition to managing those fluctuations, we are also still continuing our outreach efforts, much in the same manner as we have before, but with a much more focused goal this year. So I wanted to highlight some of the work that we've done to get you some more information about our efforts in the past, as well as to work on our engagement plan going forward. So as we mentioned many times, we use BidSync and the Electronic State Business Daily to get the word out, as well as our website, about our solicitations. We advertise in traditional outlets, and we use direct communication to vendors through short lists that we receive from our partners, as well as the business owners who are managing the solicitation with the purchasing department. And one of the things that we want to start to collect more data on and report out on is the number of people who are receiving our solicitations. One highlight I can share with you, we have a solid data source in BidSync. When we alert BidSync vendors based on commodity code about our proposals, we also get reports back from them how many of those registered users are minority-owned businesses, small businesses, disabled veteran-owned businesses. And on average, looking at the past 3 years, we were able to see that 17% of the people notified about our solicitations are identifying as HUB vendors. We also continue to participate in City, Texas Comptroller, the Chamber, and other procurement fairs as they're offered. We've had some real recent great events that we've been able to attend that were offered by the Comptroller's Office, as well as Travis County, and we continue to attend those whenever we can. So we're working more closely with our partners to make sure we're aware of those and attending those and getting the word out about Central Health. As we've talked about and we mentioned last week, we're in the process of negotiating with 4 local chambers for increased promotions and opportunities to work to get the word out more systematically through newsletters and communications to chamber members. And then also I would say we continue to partner with the city and the county on our outreach efforts, and we did take the opportunity last week to meet with both the city and the county, and I'd like to personally thank the staff that met with us on such short notice and the wonderful brainstorming sessions that we had. And I will continue to work with them very closely so that we can work smarter on some of the opportunities to share educational tools, as well as opportunities for small and minority-owned businesses to get resources to get certified or to improve their business operations. So I'd like to just hit some highlights of some of the expanded outreach planning that we want to do. I mentioned tracking data. We want to really try to track more data earlier in the solicitation process so that we are able to report out how many people are receiving our solicitation and how many people are maybe even opening it. We definitely are tracking how many proposals we receive responses from hubs. I'm pleased to say in FY19 that was about 20% of all the proposals. We had 14 RFPs or RFQs last year. Of those 14, 21% were hub proposers. So we don't have a large volume, but we do have good numbers in that response. So we want to work on tracking our data. We want to work on, as projects come together, documenting and sharing with you on a regular basis the specific good faith effort that we're doing on each formal solicitation. We also want to work more strongly with our partners at the city and the county on subcontracting opportunities. So when we have opportunities for prime vendors to work with subcontractors, a lot of this and the work that we do would be in construction projects. How do we make sure that we're linking smaller subcontractors, getting the word out about the prime contractors that may be proposing? And then opportunity to refer vendors to the city and the county's business development training. We're beginning discussions with them about how we can, again, work smarter as these programs exist. And these businesses that we are working with may be doing business with the county and the city. We would like to also develop a specific social media program. We talked a lot with the county about this. It's proven to be very successful. We have a smaller volume of solicitations, but getting a social media program up and running for our procurement department, I think will be also a great opportunity. And then, as you all know, we attend these expos and these events that are put on by our partners. Those are usually driven around a specific bond issue or a project. And so as we have those projects come together and when those projects present themselves, we will be putting those together. And those would generally be a large construction project or a big initiative where there would be a lot of opportunity for prime and sub relationships, for vendors to propose, as well as, again, the bigger specific construction projects that may come out of the development of a campus or the development of a new clinic space in eastern Travis County. So there's just some highlights of the additional work we'll be putting in and reporting out to you in I hope, a more robust and more detailed way about all the intercept points that we can have with our partners and hub vendors along the way and our program. So with that, I can answer any questions.
Thank you, Lisa. Anybody have any questions? Yes, Jim.
Just a couple of quick ones. One, thanks very much, it's very helpful and update. And I don't know if this question is an appropriate one because I'm not sure if it addresses the issue, but our relationship with Ascension, do we calculate or do we factor in at all that type of relationship and what they are doing in terms of hub vendors? Do we incentivize them to be more engaged or something, and can we reflect that? I guess is what I'm asking.
That's a great question. I am gonna look at Monica about data. I don't think we can currently capture that in our data. However, all of our contracts ask that our contractors work to have a good faith effort to subcontract if subcontracting is available. But I don't.
That's not reflected in the numbers that you show.
That is not reflected. We do not. If we have a contractor, let me put it this way: if we have a contractor who is using subcontractors, we do ask them to report back to us. That's generally, again, in our larger construction projects. And we're going to be more intentional about that going forward, trying to really push projects that we think could have subcontracting. So when we have a contractor who is using subcontractors, we ask them to report that data to us, and we pass that through into the report that you see. But that is a very limited number of vendors at this point. So it's not, so in a way, we could have better hub participation that we're not able to calculate right now. And that would be an opportunity to really look at all of our contracts. One thing I will say also is that currently, if we just think about the contracts that Central Health holds with our contracted providers, those are not considered eligible expenses because they're a professional service, a healthcare service. But that doesn't limit us from reporting out on or collecting that data going forward. It's just not a traditional way that we've reported it in the past.
Okay. Thanks very much. I appreciate it.
Any other questions? Okay. Thank you, Lisa. Thank you.
Good job.
No motion necessary on this one either. Excuse me. Moving on to agenda item 4. Take appropriate action to adopt a new purchasing policy entitled Delegation of Purchasing Duties to Purchasing Authority and Certain Officers, and to make revisions to the General Procurement Policy PUR 1-001. Lisa Owens. Again, thank you.
Still. So this is to revisit the purchasing policy that we presented again at our last budget and finance meeting. We had some great feedback from Manager Greenberg. Thank you so much. So I did include a memo. I will hit the highlights and then I'm happy to answer questions. So we did make some changes to clarify competitive bidding. Those red lines are in your packet, as well as some proposed additional language to be much more specific with the type of solicitation that could be used at those different thresholds. So where there was competitive bidding terminology, those were clarified significantly. In addition, we are working very hard to have our policies have a singular purpose. So we took the liberty of also bringing this back to you with a new policy that takes the authorization component out of the purchasing policy, so the purchasing policy has a singular purpose, purchasing thresholds and solicitation methods, and our general purchasing policy, as well, but it also had a section in there about authorizing the CEO with certain delegation and purchasing duties. So we have drafted a new policy that now takes that section out of the old procurement policy and puts it into this new policy. And we would propose that the new policy, the delegation of purchasing duties and purchasing authority to certain officers be considered by the board. So what this policy does, what the traditional authority that the board has given to the CEO, and in his absence, the deputy administrator, is it allows the CEO to execute exemption orders, execute contracts that have been pre-authorized in the budget, execute contracts and expenses that have been approved by the board in a formal board meeting, and allows Mike to make purchases that are not approved in the budget up to $100,000. This new authorization also allows Mike, the president and CEO, I should say, CEO, the ability to delegate some of his authority to additional staff. So traditionally, we have allowed delegation to the procurement authority, which includes myself and my staff on the procurement team, to execute transactions at a level that was $25,000. This new proposed policy does raise that threshold to $50,000. What we're also proposing, though, is that there are 3 key officers that the CEO could delegate authority to, and there's several reasons. Not only the growth and the changes to the organization, but continuity of services to our larger network of service providers that we have, as well as expediting routine transactions by the subject matter experts that are working in those areas. So the policy that you received last week, the draft policy for consideration, allows the chief operating officer authority on specific healthcare delivery contracts up to $100,000. Again, the funds would have to be budgeted and available in all of these cases. It provides authority to the chief information officer up to $50,000, and then to the chief financial officer up to $50,000. And then it clarifies what a prolonged absence by the CEO would be that would then allow the deputy administrator to step in and perform all of the CEO's duties upon their absence. So we've tried to lay that out very clearly, but I wanted to walk through that, and then now I'm happy to answer any questions.
Any questions on that? Do we need to do a motion first, or?
Would like to have a motion, that's the proper way.
There is a motion, Rebecca, do you want to make the motion?
I move that the committee recommend that the board adopt the new delegation of purchasing duties policy and revise the general procurement policy, PUR 1-001, as recommended by staff.
All right, discussion, Ron?
Yes, thank you. Well, thank you, Lisa. I just have a really quick question. Based on the delegation of authority for the, I believe it's under your authority, the operations, the $100,000, because all of them, the allocation is $50,000. And under the medical services line is $100K. So just the rationale, if you can just explain the
Sure.
differences with that.
Sure, so, this was similar, to other levels that we've had, but, it essentially gives us the ability to make sure that the service delivery component has a quick turnaround to be able to get the services, and those services are many times more expensive, as well as more critical. So it's a little bit higher because we wanna make sure that we're protecting the continuity of service, as well as those are the contracts with our providers who are providing services in the MAP network.
So, as long as well as our CEO's authority is 100,000 as well. So I'm just trying to think about,
Yeah, can I clarify that, because the CEO's authority is higher for anything that is budgeted. The ability to execute contracts is anything that is budgeted or approved by this board. This would really just be, we're thinking amendments, renewals, and things like that. But the CEO actually has authority to execute contracts at a higher value. I don't want to say limitless, because it has to be it has to be budgeted, and generally in the budget process, we bring you those contracts, but I'll use our primary care examples. Those are significant contracts.
I understand,
Yeah.
I just wanted further clarification
Yes,
on
and
that.
thank you for clarifying, because that is different. That is very different.
Well, thank you. Jim?
Now, help me understand, because I think I'm going to some of the questions that perhaps my colleague is. So and I understand the need to increase because of our size, our operation. One, is this consistent with what other healthcare districts or hospital districts do around the state?
That
Well,
I don't
can
have
you
the
speak to
answer
that?
to, but I can research that and find out.
The second issue is there a need to, what accountability, I guess, do we have with regards to, and I'm not questioning, but I mean, our responsibility is to ensure the accountability. If these expenditures, particularly these that we've increased it to, where is that going to be reflected back so the board will be aware these things have occurred?
So that would be reflected back in the financial reporting, increases in contracts. Many times you'll hear us talk about one of our I'll use healthcare services because that's the most important component. Right now, you might hear us talk about a contracted provider is reaching their not to exceed amount, and we want to increase that contract and make that available. So the same process would be used of informing the board that we do now, which is in the monthly financial reporting, and it would, the same purchasing policies apply. It's just allowing a small set of other executives to execute contracts in this new capacity.
And I follow that. My only question was related to, this will be a change, so this is something we would normally have perhaps seen?
Would you normally have seen if the CEO was increasing?
If, for instance, the chief information officer, I think you said $100,000.
50,000.
Oh, 50,000,
Yeah.
sorry. Would that have been something that the CEO would have approved before?
Yes.
And we would not have seen, but now it's delegating from him to the CEO, the CIO.
Yes,
Okay.
it's something that you may not have taken action on or seen executed, but if it's increasing or new, definitely new contracts that aren't budgeted, we generally would bring that to the board in the financial reporting. But currently, the CEO executes that on a routine basis as part of general operations, and those are the types of transactions, very routine transactions, anything out of the ordinary we would come to the board on. But currently, the only person who can do that is the CEO. And so this just opens a little bit of capacity and responsibility to allow additional officers to do that.
And I'm comfortable with that. My only question is auditing, some kind of accountability that this is doing, because this will be a new process. We're giving people new authority, which is fine. I have no problem with that. It's just that we need to make sure we have systems in place to account for that, is all I'm saying.
Absolutely. So we can make sure that's accounted for in an operating procedure, or we can report out on it, the process that we would, that.
Do you have any recommendation, Mr. Geisler, on how we might be able to?
I
concur with what Lisa's saying.
Thanks
You
very
know,
much.
we get some operating procedures, and really it boils down to our financial controls. And we want to give something that the auditor can look at and see the control and see that it was adhered to.
Yeah.
And so I think there's a way to put these controls in place so that somebody just doesn't take it without notifying, not just me, but you want to have at least 2 points of notification in this process so that
Exactly.
people get sign off on it. The other thing that I'll point out, and I was trying to find a relevant section here, but I think part of our process around certain contracts is we've got some new improved documentation that goes along with this, and so it passes through several hands before it even gets to me. But I think that documentation process is also critical as well.
And that documentation process would be consistent regardless of who is executing the contract. So that would be a consistent process that these officers would not be executing anything without all the signatures and the forms that we've had, that the CEO has reviewed before signing. So.
Thank you.
Any other questions? No, okay. Ready for a vote? All right, all in favor?
Aye.
Any opposed? Any abstentions? All right,
Thank you, members.
thank you. Excuse me. Agenda item 6. Discuss a potential refunding of certificates of obligation.
No, ma'am.
Oh, sorry.
Fine.
I'm sorry. Getting ahead of myself. That's what I get for taking my glasses on and off. Agenda item 5, receive and discuss an update on expanding medical access program, MAP, enrollment from 6 months to 12 months. John Morgan and Kit Abney's spouse will be presenting, and I'm sorry, I almost skipped y'all. That's my apologies.
Not a problem. Good evening.
Good evening. This is important too. Thank
Ready
you.
for us to begin?
Yeah.
Okay. Managers, thank you for your time this evening. I will very quickly turn this over to Kit. But I have the privilege of introducing Kit as well as another one of our team members in the room. As you all know, this has been a long-running effort, and we have other efforts in the same space of benefit enhancement and redesign work that's gone on for years. And Kit has led, in addition to her day-to-day duties of leading eligibility operations for us, she has also led most of these redesign efforts, from our expansion to the 50% FPL minimum to the MAP Basic program, bringing expanded coverage options for folks with chronic conditions. Kit's really helped to pull all those pieces together and then implement, operationalize, and then create those reporting out functions for us. So got a lot of confidence in Kit's work, and she's led a great team. We also have Leslie here, who is a senior project manager of ours and a nurse by training, and she has lifted a lot of this work herself and kept us moving in the right direction. So I really just wanted to recognize the two of them. I'll be here for Q&A. But just before I turn it over to Kit, as a reminder, this is a board priority as stated in the budget resolution for FY20. We're very excited to provide you with this update. There's a lot of information here. We've trimmed this down from probably close to 50 slides to somewhere around 10. So we're really trying to hit the high points, but really give you all a sense of the level of detail that the group has gone to in analyzing this initiative. So with that, I'll turn it over to Kit.
All right, thank you. And I'll just recognize another group that are not present today, but our analytics team, led by Sarita Clark-Leach, have had a huge hand in this and created probably 40 of those 54 slides that we had to trim down for your benefit tonight. So just a quick overview of what we'll go through tonight. We're going to talk about our timeline of our benefit redesign accomplishments, and then give you an overview of our MAP enrollment over the last 5 years, as well as walk you through an analysis that we have done around our MAP member renewal patterns, and share with you some characteristics and utilization of our MAP members. And then we also completed a literature review as well as literature review, and then looking at other hospital districts, and we'll share our findings with you on that. give you suggested our proposed implementation plan and the impact that we anticipate to the MAP enrollment when we move forward with this. And then lastly, we'll share the projected cost and the administrative efficiencies by implementing this change, and then go over next steps. So John kind of walked you through this timeline already. This is really just to show you that, over the last 3 years, we really have been going through a process to look closely at our coverage programs and find opportunities where we can augment, improve on them, and increase our populations. Our first one started with our income eligibility changes, where we raised the overall income level for all uninsured Travis County residents to 50% of the federal poverty level, and then allowed our non-citizens, non-legal permanent residents to be enrolled in MAP up to 100% of the federal poverty level if they had 2 or more chronic conditions. We came to you back in March of 2018 to get approval for our launching of MAP Basic, and this really is a coverage program that we have implemented as of April 1 and brings in the sliding fee scale population that we have historically always paid for. It actually brings them into our coverage population. So they are now a population that we can do outreach to, increase benefits to, unlike when they were members of a sliding fee scale. And then lastly, we wanted to show to you, we actually have been talking for several years about the increase from 6 to 12 months of MAP coverage. We actually did a lot of this analysis 3 years ago, and then we refreshed it for this presentation. So that we can see the impacts of that. Here's just an overview of our MAP enrollment for the last several years, starting from FY13. And you can see this is our unique enrollments over a 12-year period, the increase every year that we have had each year. But interestingly enough, you'll also notice that the percent of our MAP members that are actually utilizing any service has remained consistent at about 70%. So to do our MAP renewal analysis, we actually took a cohort of our population. It spanned between 2 fiscal years because we wanted the opportunity to look out a full 365 days from the last day of enrollment to see what renewal patterns were. I pulled John aside and said, of course, there's nothing like at 5 o'clock after doing umpteen million reviews of this presentation to find a typo in that in our findings, 72% of our 45,000 members that we studied actually went through the renewal process. 90% of those that went through a MAP renewal got renewed back into MAP. But 70%, not 20%, that were renewed back into MAP actually experienced a gap in coverage. And this is the population that we really are looking to address. And then there was just about 28% of our population that after 365 days of their coverage ending, we show them not hitting the system again for renewal.
Pause, Chair? Yeah, go ahead.
I have a quick question. Can you go back
Go
to
back?
the slide?
Uh-huh.
You just said the typo, is it 28 or 20?
It's 70. That typo is it should be 70% of the 29,000.
Okay, I just want to make sure. Okay,
Yes,
that was,
yes.
Go ahead, thank you.
Okay.
And if I could give Kit a break for just a second. There was also, so this is really trying to hone in on the patient experience aspect of our programs. And, when we've been vetting some of this with our partners at the medical school, with Seton, with community care, and pointed out by one of our community care colleagues, that of the people that go through our renewal process, upwards of 90% of those individuals remain eligible for our program. So it really speaks to our need to try to streamline this and make accessing coverage easier for our patients. The renewal process is often done in person, which means our patients have to take off time from work, away from their families, make appointments and come in and rescreen. When we have renewal eligibility upwards of 90%, it really speaks to our need to help streamline that renewal process. I'll also just mention quickly that you had a memo a few months back that goes into a lot of detail around the member renewal patterns. We can recirculate that if it's useful for the board. I just wanted to remind you all of that previous memo.
Yeah, it came out in December.
One more question on that
Oh,
side.
sure.
Is the number 29,277 of the renewed, because it spanned a year? Is that why it's not like upwards of 45,000 people like trying to re-enroll? So that you hear what I'm saying?
Those were the individuals that actually got renewed into the coverage. So of those 45,000,
There'll be some that are brand new.
huh?
There'll just be some who are brand new, not renewals.
In a
Yeah,
typical year, yes, the 45,000 is the unique annual number of MAP enrollees. So of that 45,000, we had 29,000 that renewed.
Okay.
But the difference between those numbers is we do have a lot of churn in our program because it's only a 6-month program.
Okay, got it. Yeah, thank you.
Yeah, this was looking at that study population, and so all of these numbers, I didn't double check that today, they should equal that 45,000. So we had 29,000 that went through the renewal process and got renewed in MAP. We had 3,300 that came in for renewal and did not get re-enrolled in MAP. They moved to sliding fee scale, and that could have been because they were no longer eligible due to income moving out of the county. It also may have been they didn't complete the process. Sliding fee scale is a much lower threshold, and then it's the 12,000 that never came back in for renewal.
So those
Got it.
individuals could have moved, they could have qualified for Medicaid or CHIP or been enrolled in an ACA plan, any number of scenarios. But we wanted to look out at least a year to see if the individuals that came off of the MAP program still access the system through a charity care program, through an emergency room, things like that. So
Okay, thank you.
that
Thank you.
portion, we just don't see hitting the system again.
That clears, I just had to do the math in my head.
Yeah, no.
The math checks out.
Okay, good. So it was just the one time.
Thank you, sorry.
This slide, I do want to point out is, it's a little bit different population. We actually looked at our last fiscal year, FY18, where we had utilization data. And I do want to point out the differences in the two columns, because one says those that were enrolled in the program 6 months or less. The other column to the right is greater than 6 months. This column does include anybody that had a gap in coverage that was less than 30 days. But as you can see, in the group that had coverage for 6 months or greater, by and large, they are 7 years older than the population that only had it for 6 months or less and did not return. And they are a sicker population, with 40% of those that remained in coverage having 2 or more chronic conditions. And then we've shared the average risk score of the population being 3.1 compared to the 1.87. When we looked at their utilization, you can see by and large there is a higher utilization, and as John pointed out, we did look at utilization both as a MAP member and if they hit the system during their gap period where they would have been considered charity care within the Seton system. And this is all just Ascension Seton data. But you can see their utilization patterns and how it is much greater in the population that has 6 or more months of coverage.
So that's a lot of pretty dense information. I think that the key takeaway, these are factors that help us lead up to how we conduct our financial analysis, because
Yeah.
we have a significant portion of our program enrollees right now that re-enroll. So there's really not a significant difference in their utilization or the costs that we're going to incur. There may be some incremental costs for sure, and we'll speak more about that. But really what we're honing in on is this column of numbers on the left that speaks to the population that did not enroll. So if we automatically enroll those folks for a full 12-month period, it's just important to note that these two segments of our enrolled population are very different. They have very different clinical characteristics. They have very different utilization characteristics that'll impact that financial analysis.
Quickly, is this information available by race and sex at all?
The FY18 population, we did not break down by race and sex. We did do that in your memo that you received back in December. We have the demographic analysis of that MAP renewal study population that we did, the slide prior that I was showing. We have it broken down by gender, household size, marital status, race, ethnicity, language. And you received 2 documents. One was the breakdown of that, and then the other was kind of the clinical characteristics by, can I share this with?
Well, you don't, I just wanted to, I'll go back and.
Yeah, if you go back and.
We'll recirculate that.
Yeah.
Absolutely.
I didn't know if I could hand this to you or not.
You can approach the witness.
Manager Jones,
If you want to thumb through it, I would talk. I intentionally printed it in case I got asked.
and I think the additional answers, we can get any of this data.
Yes.
By race and ethnicity, and I think that's what we're going to be looking for the strategic planning committee to help guide us in the development of dashboards where you want to see those breakouts. Yes, sir.
So here's some information when we did the literature review. Most of the literature out there either speaks to expanding Medicaid coverage and or moving an uninsured population into an insurance status. And so the first 2 points that we've pulled out are, when looking at Medicaid and expanding Medicaid coverage, they found that people with short episodes of coverage actually have poorer quality of health care. And a lot of that meaning because when they re-enroll, they may be going to different providers. There's no real continuity of care. And then those in the Medicaid population tend to renew their coverage when they've had a high-cost episode in hospitals, which could have been prevented in a primary care ambulatory setting. And then lastly, in the research, when they look at an uninsured population moving into coverage, there is the potential increase in hospital utilization, especially in the emergency room. And we have taken some of that into account in doing our financial analysis. The other thing I'll point out is we did look at our other hospital districts, especially kind of the districts that more align to us, Harris Health, Bear, JPS, and Parkland. Bear actually has an 11-month coverage period. They intentionally do 11 months because they want folks to come back in and re-enroll in their prescription assistance program, which is only a 12-month program because they want to capitalize on that pharmacy expenses. And then our other partners do have 12-month coverage periods. So our proposed implementation plan for this is actually pretty easy for us to implement. Our eligibility system can be reprogrammed so that it sort of automatically gives the 12 months of enrollment. We would propose that when we implement, and we are proposing an October 2020 implementation date, that we would actually go into the system and provide 12 months of coverage to those that are actively enrolled. And this helps level out the need for coming in and for renewals, and we'll talk a little bit more of that in the administrative efficiencies. And there will be some limited exceptions to that. Those that are eligible for premium tax credits on the marketplace that we move over in our CHAP program would never go beyond a December 31st enrollment period. And individuals that are going to be eligible for Medicare, we would term their coverage just like we do now. And then, of course, upon implementation, all new enrollments would get 12 months of coverage. This is just an analysis of what we anticipate the enrollment impact to be. The gray line just sort of simulates current state with our, increase in enrollment, and then the orange line really looks at what the projected implementation would be. And you would see there's that spike as we move folks into the 12 months. And then, folks don't fall off of coverage because we sort of go through a 6-month period where we're only bringing on new members and we have no attrition. And then you start seeing, so it kind of continues to climb, and then you'd start seeing the natural state where the enrollment patterns would become more stabilized. We've talked a little bit about the anticipated benefits. Obviously, it's a reduction in administrative burden on clients and on staff, and it really provides some administrative efficiencies for us. It reduces the likelihood that folks will have a gap in coverage, that they don't delay their care, they don't have expensive episodes that can be avoided. It does align with other healthcare coverage programs. And it also helps in our district data consistency as well. We are anticipating, and we'll talk about in the next slide, the additional cost and or utilization that we are expecting. Certainly an increase in pharmacy and our urgent and convenient care utilization, and then the potential increase in ED and inpatient utilization. So this is just a graph to visualize those additional costs that we would anticipate by expanding this program. You can see the FY21 and FY22 cost for pharmacy, for our ambulatory, and for our total cost. We've actually given you a range. One being sort of that extreme, if we kind of quote unquote almost doubled the utilization, what something would look like, down to there are potentials to have very little impact as we assessed just current utilization. All of these folks could have access to ambulatory care through our FQHCs. They could have gone to the hospital and received charity care. We looked at that. So costs could be minimal, but we think it's somewhere kind of in between. And that's the dots that you see are what we are projecting to be our anticipated cost.
I'll just speak for just a second. That there are two effects that are very hard for us to quantify. One is what we've kind of called the card effect of, what is the incremental additional utilization that we expect to see because someone has a card for 6 more months out of the year. I mean, as you saw earlier with our renewal rates, a lot of these folks already renew. We have quite a few patients that don't renew, so trying to estimate, how much more will someone use healthcare services because they have 12 months versus had coverage for 6 months. We think there's a pretty significant increase in our pharmacy spend, which we think is a very good thing. I mean, we want people to be able to have the prescriptions that they need to be able to control their conditions. And right now, it's a pretty a pretty scary circumstance if you've got a chronic condition that requires medication to help you manage, and you only have access to a pharmacy benefit for 6 months out of the year. That generally doesn't end well for our patients. And then additional ambulatory services, I would highlight that again, this is anticipated and often good expansion. This is what we want to see. This is getting people access to services that once their coverage ends, they may not have access to today. Most of the specialty care contracts, the post-acute care contracts, home health, those contracts are built around our MAP population. So if people fall out of MAP coverage, they may lose access to those services in the system. So it's very important. So if the board continues to want us to pursue this budget priority, which I anticipate you all do, we will anticipate these increases incrementally in our budget preparations for FY21. We will have some incremental increases in individual lines of our budget, but we will also have a service expansion reserve, so to speak, to be able to fund increases in healthcare costs across our contracted service network.
And then we talked about, we are anticipated administrative efficiencies. The greatest efficiency happens in the first year when we have that period where we've increased enrollment up to 12 months and nobody's falling off. So staff are really just doing applications for our new enrollments. And what we've done is sort of translated that to sort of an hour, the number of hours we anticipate to save. And this is time that we would repurpose to really move our population, especially our MAP basic population, where we allow folks to enroll in MAP basic even when they are eligible for other coverage. So we can spend time doing outreach and enrollment assistance to make sure folks transition to appropriate coverage programs. We also save efficiencies for our community partners. We have our clinic partners, our hospital partners, and even nonprofits submit electronic MAP applications on behalf of their clients, in which we work internally. So they would have to do that less frequently, being able to provide 12 months of coverage. So they themselves will also see administrative efficiencies. And then we've sort of taken that to a dollar amount that we would then be repurposing for other important activities.
I think this is an area that's just hard to conceptualize, but when you think about us having 45 to 47,000 MAP members a year, that's at a minimum one application and one eligibility determination for each of those 45 to 47,000 individuals or household members each year. That is a lot of effort, and streamlining this process, having continuous coverage, obviously creates some significant efficiencies there.
And then our last slide for next steps. Obviously, this is an informational item, and so we would need Central Health and Ascension Seton agreement on implementation and timeline. I would like to add a couple more bullets here because I skipped over it on my timeline, and just that I wanted to say we have several kind of initiatives going on around benefit redesign that you will begin to hear about, as well as this 6 to 12 months. We are actively pursuing an online MAP application that we do not have, where folks will actually be able to take pictures of documents and upload them securely. So that we are hoping to have in place before the end of the year. We are United Way of Texas has let us know that they would like to end our call center contract with them and services, and so we are actively engaging with community care to talk about a call center strategy that we can implement together. And as we do that, really looking at the efficiencies of making sure that folks can apply over the phone and how they easily submit documents. So really rethinking what a call center might look like for eligibility enrollment and post-enrollment services. We also are working on an RFP to look for vendors that can help us do on the back end some eligibility verification, whether it be verifying Travis County residency, income status, and/or do folks get enrolled in other insurance and fail to report it, and we can find that out in term coverage. So I did want to say that all of this feeds into this kind of this redesign work that we are doing that we really feel like will benefit our members as well as just the efficiencies of our staff.
Yeah, in today's market, there's no reason that our patients shouldn't be able to take a picture of their eligibility documents with their phone and send it to us. That's really where we're headed. A lot of our patients have smartphones, and if we can help people avoid a trip to the eligibility office, we want to try to move in that direction.
That's fab. Thank you. That was an excellent presentation. Thank you.
ma'am.
I know Manager Valdez will be very happy. Ms. Chair.
Yes, I think I'm channeling her. We started together on this board on the same day, but yes. And I am ecstatic because this is something that Manager Valadez and I have spoken about since we first arrived on this board. I want to thank you for your tremendous work, and I for one would hope that we can proceed with this with all due haste, and I also am very happy to hear about the online eligibility that you're pursuing. So thank you, and all the staff members who are not present for all their hard work on this.
Thank you. Yeah. Ms. Mom.
Thank you. Well, thank you so much. Appreciate it. This is great progress, and I'm looking forward to it. The only concern that I have is in terms, I love technology and everything that entails the security and maintaining their privacy. Have you taken that into account and consideration?
Yes. The vendor that we work with, and certainly all of this will go through a legal review, but everything that we do will be HIPAA compliant and ensure that it is safe and secure. I will say we will always have an in-person option because yes, many of our clients have smartphones, but there are folks that are not comfortable sharing information in that way, and so we by no means are looking to eliminate in-person applications. We just want to broaden the reach that, like I said, whether it be over the phone or late at night, somebody can get on and do this process, especially renewal members. But we will absolutely vet the security with our joint tech folks and our legal team with any online tool.
The
We're
convenience.
developing our online application with our longstanding vendor, Network Sciences. This eligibility system, they've provided that backbone infrastructure for us for a long time. Community Care is also looking at eligibility options through their EHR, and as you know, this is a highly regulated area with a lot of security and privacy provisions that we'll have to take into account as we're doing this. So that's part of the reason why it's such a lengthy process, is to make sure that this is up to the standards that it needs to be.
Wonderful. I just wanted to bring that reassurance. And one last question. Why is United Way no longer hosting our call center? Is there a reason?
Please.
I think they have been reevaluating their mission, and though obviously serving our population is key to their mission, there are other things that sort of supersede that in the more population health, early childhood, things that don't quite align. Our call center activities are very rote in nature. They do a thorough eligibility screening for us and assigning of appointments. And I think they are really looking for opportunities to expand in their 211 and their services where they're doing more of the avenues that better align with their mission.
I was just curious.
Yeah, it has been a very amicable, they have worked with us, they're giving us over documents and said they will do everything they can to help make sure we're successful, and have given us a year's notice. I mean, the contract allows for a much shorter termination period without cause, and so I think it's run its course.
They've been great partners and
Yes.
continue to be in this process. I will say this opens up a new opportunity for us to really work with community care. You all know they have a very highly functioning call center, and we're in the process of working with them to develop plans
I was
to
just curious, I'm not
operate the
questioning
service
anything.
jointly.
One last question, it's actually a request in the future. Once this hopefully gets implemented into place, a year later, if you can provide us, I don't know if I'll still be on the board, we don't know what happens a year from now, but in terms of utilization, to see if that extending the 12-month mark has increased utilization. So just curious about that.
I'm actually really glad you brought that up. So there are a lot of, again, additional slides behind this. There are utilization measures that we'll want to track in real time just to see if our projections prove out in this process. So we'll need to monitor this closely. It's not an insignificant investment from the Board of Managers.
Thank you so much.
Yes, ma'am.
Just one quick question. What are you doing to market, excellent presentation, Chris. But what are you doing to market the online application? Not the online, but the iPhone application.
It hasn't launched yet.
No. When you do, what are your strategies for doing it, I guess is what I was saying.
Oh, well, we will work closely with our VP of Communications, and we'll use social media tools and our community health workers and, paid media to.
I think that's great. That's a fantastic opportunity. I would just want to make sure that all of the buttons are touch-based to make sure that occurs, because I think that will increase visibility about the program, and so I think that I just want to make sure, and obviously working with Ted, I know it'll be done well, so thanks.
I'd highlight one quick thing just for the board's awareness. Another thing that Kit's been instrumental in moving forward with us, and Holly's really taking the lead on this as well. Kit mentioned we've been making some updates to our forms that are part of our application process. One of the big drivers of that is to enable us to collect authorizations from patients to be able to send them text messages and emails if they choose to receive those. I think that'll be another big opportunity for us to push out the availability of this, as well as other things that we need to make our patients aware of from time to time.
Anything else? No? Thank you all.
Thank you for your time.
Wonderful. Thank you so much. No action is necessary on that one. And now moving to agenda item 6. Spoiler alert. Discuss a potential refunding of certificates of obligation issued by Central Health in 2011. Jeff Knodel will present this item.
Thank you. That's hard to follow since you did a real presentation, so you guys may have to bear with me a little bit. Unlike the preceding item, this item's been very fluid. In fact, we found out about it somewhere around Friday afternoon, so let me get into it. So what we're talking about is there'll be some terms that you may not be familiar with. The analogy that I would use, just trying to think through the process, is contemplating refinancing your home mortgage. So that's kind of the analogy that I think fits what I'm talking about. So just to summarize, in 2011, Central Health issued. So Central Health issued certificates of obligation series 2011 in the amount of $16 million. The goal of what's called the refunding, or the analogy being a refinancing, is to achieve financial savings. And being a government entity,
What that means is on the debt service side, which is where we pay for our outstanding bonds, we would reduce the amount of taxpayer funds required for those debt service payments. This is a informational item only, but pending market conditions remaining favorable, we plan to be back to the board meeting on March 25th to request approval to move forward, and I'll talk a little bit about that in a subsequent slide. So as I mentioned, in August of 2011, Central Health issued these certificates of obligation in the amount of $16 million, and this is our only debt that we carry on our financials. The outstanding amount to date is a little bit over 7.2, almost 7, excuse me, $7.3 million. I talked about a mortgage refinance. In the bond world, it's a little bit different. In a mortgage instance, you have a lot of choices. Certificates of obligations, our issue, there's a provision called a callable provision, which basically means that you cannot refund or redeem the bonds past a certain or up to a certain period of time. And so the terms on our certificates of obligations were what's called callable on March 1st of 2020. So that was very recently. And as I noted, there's been a lot of volatility, a lot of changes in the financial market. Other than the way markets have been reacting, the financial markets, you probably noticed interest rates have gone down substantially. And so that's what's prompted PFM, our financial advisor, alerting us that these bonds are callable, and there look like there are apparently some favorable conditions that we may want to contemplate refunding these bonds. So I did a chart down at the bottom of this slide. It shows the interest rate for each year. So when you issue bonds, they all have due dates in what are called tranches. And so this is each tranche, and you'll notice the interest rate. So if we issued in 2011, the interest rate was really low in 2012, right? It's a real short-term bond. The interest rate's pretty low. And as you go out over time, the interest rate increases. When we issue our bonds, our interest rate range was from 0.5% up to 4.25%, with the 4.25% being in 2026. We've paid bonds through March 1st of 2020, and so you see the red line that kind of draws that distinction. The outstanding rates that we have left on the life of this series ranges from 3.63% to 4.25%. So in a nutshell, we've paid off the lower interest rate amounts, and we have the higher interest rate amounts remaining just because at the time of issue they were longer term. So what are some of our objectives? So if we're thinking about refinancing, what are some of the things that we want to think about and achieve? One thing that we want to achieve is we want to have the same term or length of the issue in place. In other words, we do not want to take a series or a partial series and then refund it and extend it out unless there were favorable reasons to do that, which at the time there are not any. So we want to keep the term the same at a minimum. We also want to achieve savings of at least 5%. And then tangibly, we want to achieve at least $500,000 of savings over the remaining 6 years of the debt, which averages out to about $75,000 per year in interest savings. Because the market's fluid, we need to try to take action as expeditiously as possible. So we are utilizing our banking relationship with JP Morgan to actually do what's called a private placement. So we don't go out for a long competitive bid. We're actually receive very competitive rates in a more private placement. A private placement actually, traditionally, the rates may be a little bit higher, but the actual issue costs are a lot lower. I think in this case, we may be getting a lot of both of those worlds based on the rates that have been quoted and kind of getting some feedback from PFM, again, our financial advisor. And lastly, but certainly not least, is market conditions are changing a lot. Based on what we're seeing, we want to try to act to lock rates as quickly as we can. So next steps, again, we'll be coming back to the board, or I'll be coming back to the board on the 25th to ask for approval to issue a refunding for the remaining amount of the Series 2011 COs. We'll request approval through what's called a parameter cell, which is much like what I just laid out under the objectives. So we'll ask for consideration to approve the refunding of the Series 2011 COs based on certain, a floor of certain savings and objectives that we would have. And that would basically be around the percentage of savings and the dollar amount. And again, use whatever instruments or techniques we can utilize to lock our interest rate, and then evaluate if we're still looking into if we need to get approval for a refunding from the Commissioner's Court. So we'll look into that. And if so, we'll probably try to go that next Tuesday after the meeting on the 25th. So I know the chart on this page looks almost identical. Really the only change in it is I've just done a kind of an estimate of, a conservative estimate of where I think the blue dotted line kind of shows hopefully a conservative estimate on where we're at on interest rates thus far. So you see kind of the gap between the solid blue line and the dotted blue line as far as interest savings that we would achieve over the remaining life of the bond series. So I think the market's very favorable for us to consider taking action. At times you have to ask yourself, is the dollar value worth all the effort to go through a refunding? I think the private placement offers a real efficient way for us to execute a refunding, and it achieves the savings objectives that I think are meaningful for us to provide more, to utilize or lower our tax rate to our taxpayers. Excuse me. So that's all I have. I'll be happy to answer any questions. And again, I'm planning to come back in the next 2 weeks unless market conditions change substantially, and it's just not, the conditions are not favorable for us to proceed. And then we'll probably just be in a hold pattern to monitor the market. But the rates change really quick, and the bonds became callable on March 1st, which was a trigger date. So we're trying to move as quickly as we can to lock in savings. Thank you.
Thank you. Thank you. Any questions?
Now, certainly, we appreciate you really, hopping on this, and it looks like substantial savings. Typically, you want to see at least, 2 percentage points, and you're showing much more than that here. So hopefully we can achieve this.
Yeah, that would be the hope.
Yes.
I just want, the volatility is just unbelievable now, so the question is, the sooner the better, I hear what you're saying, so on the 25th, we'll be addressing that at that point in time, because between now and then, we don't know what'll happen.
That's right.
Is there any opportunity we would need to call an emergency session to lock this in?
We're gonna have to research the Commissioners Court
Right.
requirement.
Right. Okay.
It's hard to say. I think interest rates have ticked down again today. I don't know what index drives our rates. But we'll continue to monitor it. There's just really no predictability. And it will take us a little time to actually get all the necessary documentation and paperwork. But what you'll see next meeting, our financial advisors will come in and they'll brief the board on what, kind of more specific terms and request permission to issue the refunding.
Thank you. Thank you. Any other questions? All right. No further action. Thank you, Jeff. Agenda item 7, confirm the next regular committee meeting date, time, and location. Managers, our next regularly scheduled Central Health Budget Finance Committee meeting will be held on Wednesday, April 15th, 2020, tax day, at 5:30 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion for
Move
adjournment.
adjournment.
I knew it was going to be second. All right, Ron got the second then.
I beat you.
All right, all in favor?
Aye.
All right.